In spring 2018, Reverend Dr. Clint Moore, director of the Center for Clinical Ethics at Advocate Lutheran General Hospital in Park Ridge, Illinois, spoke to a group of myasthenia gravis patients. He addressed making difficult treatment decisions when you're ill. Here's an excerpt from his talk.
Physicians will frequently ask this question. John, you have this condition. We can do A or we can do B. What do you want us to do? Well, I think that's a cop-out by a physician. I think a physician ought to make a recommendation, and then you ought to be able to ask questions. But it really skips, what do you want us to do is a question about an intervention, not a goal. If you haven't already talked about what you're trying to achieve, how can you really make a decision about an intervention, right? So this is a physician who's been treating patients with myasthenia gravis. While there are treatment options available that can help manage symptoms, in fact, as many as 15% of MG patients will have refractory MG, meaning that despite current treatment, they continue to suffer from debilitating muscle weakness that severely impairs their ability to engage in simple daily activities. Well, how do you know that you're in that 15% or not? I mean, the symptoms range so widely. Everybody sort of experiences those differently, right? And you're not a number. So these are studies, but studies shouldn't make you a number. You're still a person. Common symptoms include, I'm not going to go through all of those, you know them better than I do, but between 15 and 20% of MG patients will experience a myasthenia crisis at some point. Patients with MG have increased risk of post-operative adverse events. So patients with MG who have a major surgery tend to do worse after the surgery. Well, if you think about it, that makes some sense. I'm not excusing it. It's just, think about it. Your reserves are lower. Plus, surgery has done what? It's initiated an immune response, right? So MG is an immune-mediated illness. So if you have a big surge in your immune response, you're probably going to have increased weakness or increase in some of your other symptoms. So it's not a reason to stay away from needed surgery. It's a way to say, look, doc, here's the issue. Here's what concerns me. I think if I need surgery, from having my gallbladder taken out to whatever else, I want you to know that, I had this bearded guy come talk to us at this lunch the other day, and he raised this issue. Is that true? And the physician may say, well, I'll read up on it, or yes, that's true, but what we're going to do is get you through that crisis. So your post-operative recovery might be a little longer. Okay, so if you plan for that, everybody knows that, rather than expecting a response from someone or like someone who doesn't have MG. So here's a little thing I love this. We have all these pictures around the hospital, eagles soaring over snow-capped mountains. Together as a team, we can soar to new heights. This is a great one because I was a rower in college, and I'll read it to you. So here's a four-man skull racing across this, sun-dappled lake. You'll notice the direction in which they're going, everybody has their back to, right? So it says ignorance. It's amazing how much easier it is for a team to work together when no one has any idea where they're going. So the one thing that I always stress with physicians and families, and what's your goal? What do you hope to achieve? Because if we don't know that, how can we, then why, if your goal is not to do this, then why are we even recommending that intervention? Yes.
Do you think it's important, like, to talk to your doctor in terms of ask emergency action plan in place?
Absolutely. Absolutely. And talk to him or her about, you know, what are your fears? What are your hopes? What can he or she tell you about what the expectations are? And then, you know, not only should that be communicated to you, but to your family, so that, you know, now it's day 2 and you're not, you know, your next door neighbor had this surgery last week and they're already out of intensive care, or already off the surgical unit, or already out of the hospital. So, you know, you have to take into account that you may need to ask more questions, but you know, the two-edged sword is you already know what you're dealing with to some extent. So you can help educate your physician around, here's what I need to set up for you and for I to get through this. But avoiding, you know, saying, well, no, I'm going to wait on that surgery till it's an emergency. Oh, please no. You know, that rarely turns out well. It just doesn't. It's always better to do a procedure, whether it's big or small, when you can control it, when it's not an emergency. When things get to be an emergency, you lose some semblance of control, either real or imagined.